has almost the entire market share and does have the entire market share in Colchester, Williston, and Shelburne. Market share in St. Albans has increased compared to 5 years ago, 5 years prior to 41.7%, despite Northwestern's location there. Market share in Plattsburgh has also increased. Moving to quality, UVM Medical Center's current star rating is 3 out of 5, and their patient survey rating is 4 out of 5. Their star rating in Q2 of 22 was 5 stars. In April of this year was 4, and it's now dropped to 3 stars. We see here listed some metrics in which the medical center performs better than the national rate, along with some that are worse than the national rate. Perhaps most notable is the medical center is the worst performing hospital in the United States for accidental tears and cuts from medical treatment. Looking at the top right graph, we can see that UVM Medical Center saw a payment reduction for value-based purchasing program of 0.16%, a payment reduction of 0.18% for the readmission reduction program, and a 1% payment reduction for the hospital acquired condition reduction program. The bottom right graph is looking at some ED metrics. We see the average time patients spend in the ED before being sent home was 256 minutes. This is higher than the national average for other very high volume hospitals. The median time psychiatric mental health patients spent in ED before leaving is 345 minutes, which is higher than the national average, but slightly lower than the state average. Finally, the percentage of patients who left the ED before being seen is at 3%, which is higher than both the national and the state averages. So staff's recommendation is as follows. We're recommending a reduction of their commercial rate of 7.3%, reducing it from a proposed 2.4% increase to a 4.9% reduction. We're recommending a commensurate decrease in their NPR and commercial NPR by the amount of rate reduced. We're recommending that the further reduction related to those 14 executive positions that were previously identified. We're recommending that UVM's budget be reduced by the approximate allocation of that increase, or 465,708. And then we're also asking for a commensurate expense reduction associated with that executive salary decrease.
So I can step in for a minute to go over one more item for UVMMC. And Matt, just to confirm that NPR reduction is that's the margin figure.
That's correct. Yes.
Operating margin.
Yeah.
Okay. So Chair Foster, before going to board questions, I was hoping to go over one additional set of budget order conditions that staff are recommending for UVMMC. And before getting there, I'd like to just do a little background to explain the rationale as to how staff got there and where in the budget assumption staff is expressing some disagreement with what UVMMC has submitted. So if you go to the next slide, Matt. So as a starting point, a reminder that in UVM's budget submission, there was a proposed reduction with all required rate reductions included, a proposed reduction to rate, and additional to that proposed reduction to rate, a request for an increase to charge master. So UVMMC requested a 3% charge master increase as part of its budget. To explain the rationale for needing a charge master increase, UVM pointed to two reasons that this was necessary. UVM explained that decreasing charges to match commercial reimbursement decreases could have unintended consequences. The first is that government payers like Medicare might pay less for a service if the effectively might pay for a service the lesser of a hospital's charge or a specified rate. So if the hospital's charge on its charge master were to decrease below the specified rate, then the hospital would receive the lesser of payment from Medicare. That was one rationale for requesting an increase on the charge master. The second is that CMS uses hospital charges to calculate the hospital's cost to charge ratio on its Medicare cost report. So the idea is that decreasing charges could impact that calculation on the cost report, and that could result in lesser Medicare reimbursements. So that explanation was in UVM's budget narrative submitted with its FY26 proposed budget. On the next slide, you'll see some responses from UVM to staff requests for information. So staff asked first about the cost to charge rationale, that second item. And what UVM explained was that a change in the cost to charge ratio will potentially impact Medicare reimbursement for very specific services where Medicare reimburses codes based on cost rather than in other ways. UVM also explained that only physician services are reimbursed based on the Medicare fee schedule. Only physician services reimbursed on the Medicare fee schedule are paid at the lesser of rule that was described in the budget narrative, and that inpatient and outpatient services are not generally impacted by the Medicare lesser of considerations. So the takeaway here, as far as staff understand what UVM is referring to, the first piece is that the lesser of concern that UVM had is really only to specific physician services that would have this lesser of issue potentially impacting what UVM got from Medicare. And the concern about the cost to charge ratio being impacted by a charge master decrease and leading to less reimbursement for services would only apply to very specific services where Medicare is reimbursing based on that cost to charge ratio as one of the factors. If you go to the next slide, there was some more follow-up on this to really try to understand it. So staff asked for more information about the lesser of implication that UVM was concerned about. Staff asked for any services that could be impacted by the lesser of rule, to which UVM responded that it makes every attempt to ensure that it receives the maximum allowed Medicare reimbursement for professional services at an individual CPT code. Staff also asked how UVM has historically targeted increases to its charge master, to which UVM responded that its pricing methodology starts with multiple Medicare published payment schedules, along with other Medicare data points to create a basis for charge master pricing. And then service category markups are applied to those base amounts along with additional inputs, and then also lesser of implications. So the takeaway that staff got from this response was that UVM's method of establishing charges on its charge master appears to already incorporate what Medicare pays and any lesser of implications. So the concept of additional charge increases being necessary, if applicable, seems limited, I think would be the fairest way to explain that. And then moving to the next slide, staff asked more questions as well about this this cost to charge ratio concern with certain services that that Medicare reimburses. Staff asked for a quantified response to what the impact of not approving a 3% charge master growth would be. And what UVM responded with was that the FY24 Medicare cost report reported in total $627,000 in cost-based reimbursements. I'm happy to be corrected on this by UVM, but I believe that means that out of all Medicare reimbursements in FY24, $625,000 is the total amount that was subject to any cost-based reimbursement methodology for which the cost to charge ratio would be relevant. So any impact to the cost to charge ratio that would reduce reimbursements from Medicare would be a reduction off of what appears to be a relatively small percentage of UVM's total Medicare reimbursements. So those are the responses that staff have gotten at this point from UVM on this issue. So going to the next slide, I'm going to start with UVM's request for charge master growth. So staff, after reviewing, disagree with the assumption that charge master growth of 3% is necessary to avoid meaningful consequences. That's what UVM said in its budget narrative. With these follow-up responses, it doesn't seem to be the case. The lesser of rule, according to UVM, applies only to its physician services. UVMMC already uses Medicare payment schedules to set charges, and many charges are set above Medicare reimbursement. UVM, in the staff opinion, has not met the burden of demonstrating that a reduction to charges in its Medicare cost report would result in lost Medicare revenue. And to the extent it may be an issue, cost-based reimbursement is a very small portion of UVM's Medicare revenue. So for those reasons, staff are recommending that the board not increase the charge master, the aggregate charge master growth. I'm going to turn next to what staff are recommending, which is a different way of conditioning and regulating UVM's reimbursement rate and charge master changes. And to get to why staff are recommending that the board apply stricter regulation on UVM, I want to give a little bit of history for how staff understand UVM to be negotiating commercial contracts in a different manner than other hospitals in Vermont, and in a manner that is not consistent with the state's healthcare goals. So what I'm starting with is a letter that we received, I should say very helpfully, from UVM last year, when there were allegations from Blue Cross Blue Shield of potential overages compared to what UVM and Blue Cross had projected for prior year payments. I want to be very, very clear up front that the board has made no finding at all about whether or not Blue Cross Blue Shield was overpaid UVM. There's been no hearing on this. This matter was effectively resolved in the board's settlement agreement with UVMMC and the network. UVM and the network were very collaborative in reaching that settlement agreement. There's no determination that staff are making here about whether or not UVMMC was overpaid by Blue Cross. However, while this discussion was going on last year and the board was getting letters from UVM and from Blue Cross about this issue, UVM did explain and identify the process that it uses to set rates and charges and negotiate these rates with insurers. And this is where staff have concerns. It's not about whether there was an overage in the past, it's about the actual process that is being used to set rates as explained by UVM. So as a starting point on this slide, what UVM is describing here is that the board is setting a aggregate rate cap and charge master cap. Let's say it's growth, right, of something like 3%. The board is saying that the aggregate rate can increase by 3%, but at maximum, that's the cap, and the aggregate charge can increase by 3% at maximum, that's the cap. And what any hospital in Vermont can do with those caps is make any changes to their charge master and rates underneath those aggregates. For example, by reducing charges in some areas and increasing charges by other areas, and in turn reducing rates in some areas and contracts and increasing in other areas. So long as the aggregate cap is not exceeded, then the hospital is compliant with the board's budget order. What we've heard from a lot of hospitals is that their process of changing charges and changing rates is relatively streamlined and uniform. There might be some exceptions to this, but broadly speaking, there are not very, very large, complex changes in charges and rates. And to kind of just walk this out for a second, if a hospital is making very large changes to charges or to its negotiated rates with insurers underneath those caps, there's a lot of additional modeling that's necessary to ensure that those changes are not going to result in aggregate increases over the board's budget orders. So, to say it simply, a hospital that makes a lot of changes underneath the aggregate cap is going to need to engage in a lot more modeling with an insurer to ensure that it's complying with the board's order. What UVM described is that it has what it describes as a painstaking process of working through large changes to its charge master and its rates with Blue Cross every year. And it's a process that spans many months and involves a lot of administrative time and burden for both UVMMC and the insurer. Um, Very helpfully, UVM provided the board a walkthrough of what this process looks like typically on an annual basis. And I do want to take the opportunity to walk through that process to demonstrate how much administrative input is required to make these large changes underneath the board's aggregate caps. So these are charts that I'm going to present on the next few screens from UVM, from the letter that it submitted to the board last summer. And I'm just going to go through this just point by point. So as a starting point, UVM describes that from March through August and then ongoing, as I understand it, UVM and Blue Cross, and here we're using Blue Cross as an example insurer. It's one of the major insurers in the state. UVM and Blue Cross share negotiation objectives, including any methodology changes. They discuss Blue Cross Vermont's findings in pricing transparency files, and then the health network sends a charge master increase letter to Blue Cross by July 1st. Ongoing are multiple calls that are required to walk through the detailed analysis that's going to be broken out below. First, Blue Cross sends the health network a production file, a download from Blue Cross's system by CPT code and service type for all inpatient, outpatient, and professional rates, including percent of charged terms. That happens in July. And then second, the health network uses the download from Blue Cross to prepare a proposal of rates and which it sends back to Blue Cross. The health network's proposal may include increases to certain codes and decreases to others, always in compliance with the board's budget order. And I should add that my understanding of how compliance with the board's budget order occurs is that UVM and Blue Cross are modeling not only what any increase or decrease is to a specific service, but are also looking at historic utilization assumptions so that both price and utilization can be incorporated together to arrive at what the expected commercial revenue result will be for any given service. Going on to the next slide. The next step that UVM describes is that from October through November, both parties will outline the data set each will use for modeling and analysis and the aggregate percentage targets. Fourth, for CVMC and Porter, the health network reaches out to Blue Cross to ask if community professional fee schedule is changing. Fifth, confirm the impact of DRG weight changes using most recent weights from CMS. And then six, Blue Cross does an in-depth analysis of the proposal that the health network sent, focusing on large increases or decreases by code, any newly added or deleted codes, etc. Seventh, Blue Cross then provides feedback with its findings to the health network and meetings scheduled to review findings and discuss next steps. And then going to the next slide, Blue Cross and the health network exchange emails and detailed spreadsheets outlining changes to confirm intentions. This involves significant review of fee schedules and details of the analysis. Blue Cross Vermont is transparent regarding their inpatient, outpatient professional volume weights used in modeling and how UVM's terms are valued using their weights. UVM provides the weights in the data that it uses. 10, Blue Cross requests rebased codes to be added as a fixed fee versus percent of charge. These are codes that were paid at a percent of charge, but have more than 5 units of volume in the past year. 11, contracting teams from Blue Cross and the health network work together to determine areas of improvement. That's March through contract execution. And then 12, the health network marks up a paper copy of the reimbursement terms of the contract and provides to Blue Cross. Both parties review to ensure it accurately represents the details of the negotiation. So I want to point out that there are items in that process that may be necessary for contracting regardless, but the scope of complexity, the number of meetings, the amount of back and forth that is required here appears to be directly linked with the scope with which UVMMC in particular has these many charge master and rate adjustments that are happening underneath these aggregate caps. So moving on to the next slide, setting aside the administrative complexity of this process, staff have also observed a trend in the last 2 years in which UVM has in an unanticipated way gone over or is projected to go over what it had budgeted for commercial NPR. To be clear, the board has not set commercial NPR caps in FY24 or FY25. That is a new condition that staff are recommending for FY26. Nonetheless, the hospitals do budget commercial NPR and submit those budgets for approval to the board. In FY24, again, this was resolved in the board settlement agreement with UVM. There was a $26 million or 2.4% overage in commercial NPR. In FY25 projected, this is setting aside the mid-year adjustment, a $95 million or 7.3% overage in commercial NPR from budgeted. So looking at those two overages from the last years, the concern that staff have is that the complexity with which UVM is modeling the charge master and rate changes under these aggregate caps is leading to less consistency and ability for the hospital to align its actual performance with budget. There are likely other factors that are impacting and that have impacted those overages. Staff are not saying that the complexity of price changes is the only thing that is resulting in this, but there appears to be a clear nexus here. So taking all of this together, staff recognize, and you can go back a slide, Matt, if you mind. Staff recognize that UVM's discussion of multiple factors that have contributed to NPR cap overages is I'll say it differently. Staff recognize that there are other factors that may be contributing to these NPR overages. However, UVM's what it describes as a painstaking process of setting charges and negotiating rates under the board's caps is administratively complex. And it's led in part, staff believe, to unpredictable UVMMC budget performance in the last few years. With this level of complexity in contracting, it's also challenging for staff and we think the board to understand nuanced factors that are impeding cost containment. Staff also believe that less administrative spend on complex contract negotiations can help UVM achieve lower operating expenses, which is a clear theme, I think, of what staff have presented today as an issue for this hospital's performance. Next, reducing complexity in charge and rate adjustments will result in more consistency, transparency, and fairness to patients who are paying for these services. Having big swings in what the price of a particular service is not, in the staff opinion, of benefit to Vermont patients. And finally, staff recommends stricter regulation of UVM's commercial rate and charge adjustments for those reasons. So going to the next slide, staff believe that this recommendation is consistent with the board's statutory charge. Simplifying UVM's inputs when negotiating rates is consistent first with the principle for healthcare reform that overall healthcare costs must be contained and that the healthcare system must be transparent in design and accountable to the people it serves. We think also relevant is that Vermont's healthcare system must include mechanisms for containing all system costs and that the financing of healthcare in Vermont must be sufficient, fair, predictable, transparent, sustainable, and shared equitably. Next, the budget statute provides that budgets established by the board must promote efficient and economic operation of the hospital. We believe that less administrative burden and spend on complex rate adjustments and charge adjustments under an aggregate will help the hospital achieve better, efficient, and economic operation. And finally, budgets established by the board must reflect budget performance for prior years, and staff are concerned about these prior year overages from budget on commercial and PR. So with that in mind, staff are proposing two categories of conditions for UVM. One category applies to rate and one category applies to charge. So I'm going to walk through rate first. First, and these would be, to be clear, these would be specific budget order conditions for UVMMC in lieu of the aggregate commercial reimbursement rate caps that appear more appropriate for the other hospitals. So what staff are recommending is that first, UVM's commercial reimbursement rate shall be reduced by at least whatever percent the board determines under the FY25 approved level. The commercial reimbursement rate for each payer shall be reduced by at least that amount under FY25 approved levels. That maps to what is recommended as a condition for other hospitals. Second, for each payer, UVM's commercial reimbursement rate for each individual service shall be reduced by at least that percentage amount under the FY25 contracted amount. In other words, if there's an aggregate, let's say an aggregate change of 0%, then that means that every rate would be changed by 0% from FY25 to FY26 for each service. Second, the commercial reimbursement rate overall with respect to any payer and with respect to any service may be less than that amount as negotiated between hospital and payer. That's again consistent with the template language for other hospitals. And finally, UVM shall comply with the outpatient prescription drug limitations defined in Act 55, Section 4. Turning to charge conditions, staff recommend the following. First, that UVM's overall charges be reduced by at least whatever number the board determines under FY25 approved level. Second, that UVM's charge for each individual service shall be reduced by at least that amount under the FY25 amount in alignment with its reduction to rates, meaning that if the board were to make a reduction as staff are recommending to UVM's reimbursement rate, that same amount would be a reduction to the charge, and every single charge on the charge master would go down by that amount. So no shifting of charges underneath an aggregate. And finally, recognizing the physician service issue that UVM identified, if any reduction to charge for a physician service would result in less Medicare reimbursement under the lesser of rule, UVM may set its charge for that physician service at the minimum amount necessary to ensure full Medicare reimbursement. So this would be a little bit of a carve out, which would allow the hospital to get maximum reimbursement from Medicare for those services for which it expressed concern. So that's the end of the staff presentation for UVM. Before I turn it back to you, Chair Foster, I would like to address one small omission from a slide that I presented earlier, which was the standard conditions for all hospitals. And what I'll do is just quickly pull up the slide that I have here. So what I showed earlier were the draft conditions for hospitals. I showed this slide, I showed this next one and this last one, but I mistakenly clipped the final slide. So I just wanted to present that final slide here. These are the draft conditions. That was just a repeat of what staff had already presented on August 5th. But I clipped one of the slides that we presented on August 5th and wanted to bring that here. So that slide is here. Again, this applies to all hospitals. This is staff's recommended standard budget conditions for all hospitals, except for any specific conditions applying to specific hospitals like we just talked about with UVM. Everything here is the same as what was in budget orders last year. The only difference is an additional requirement that the hospital report its actual variable payments and incentive plans for executive and clinical leadership no more than 15 days after being adopted by its board of directors. So that's the only item that I want to just make sure that I included in so that that record is complete. I think that's not in the PowerPoint that's on the board's website, but we will make sure that that gets updated so it includes that slide. And with that, Chair Foster, I'll turn it back to you.
Great. Thank you both so much. Mr. Sutter,
Chair Foster, can I correct one thing I said earlier? You had asked or just slightly modified. You asked a question about network assets and thinking about how they could be allocated or thought about at the individual hospital level. I just off the top of my head suggested maybe that it could be allocated similarly to how they consider shared services, which is, just looking at hospitals' percentage of revenue. Thinking about it more during the CDMC and Porter presentation, I don't think that's actually a wise way to do it. The assets are, simplifying it a little bit, there's nuance, but the assets are basically driven by gains. So expenses, revenue less expenses. So I think you'd have to consider that in terms of allocating the assets by the hospitals or considering the assets, the network held assets at the individual hospital level. I think you would need to consider contribution to network income to do it appropriately. So I just wanted to add that because I did just off the top of my head mention I thought revenue would be an appropriate way to do that, and I do not believe that now.
Okay, and maybe that's a point for clarification with the network. And I would echo that the network has done a really good job responding to our requests and getting us the information we want. And that's really helpful to everyone trying to solve the problem. So I wanted to call that out. And this is one that I am interested in because it looks like from the RFIs that there's about $262 million in assets at the network. And the funding of those network assets I have calculated up to be $300 million, $50 million from MC in 2018, two $75 million tranches in 2020, and then a $100 million tranche in 2022. So one, it's below the amount of money that's actually put there. And so there's a question of where did that other $38 million go and what was it used for? And then second, presumably, based on how they're held, there should be interest. You have 7 years of interest on that $50 million tranche and 3 to 5 years on the other $250 million tranche. So there's a lot of money that we don't know where it went as we sit here today relating to those cash infusions. Secondarily, we don't have an understanding right now as to how much of that money should be credited towards UVM, if any. I saw the responses said that the money is held and managed at the discretion of the network, but some amount of that money should be, I think, allocated to the hospitals that pay for that money to be there or gave that money up to the network. So that's something that I think we need to get a little bit more clarity on because it's a significant amount of money, especially if UVM, some of it's their cash that they put there. It could change the look on the day's cash on hand. And it influences, I think, to me, the staff recommendation. You're recommending that there are no reserves. And part of that is, well, what are the reserves truly? And we know there's a significant amount of money that's been taken out of reserves and gifted, loaned, fund flowed over to New York. That also changes the financial picture of the medical center that you're making a recommendation on. So I do want to get that nailed down because I don't think we can responsibly make the decisions we need to make without it. And I'll follow up with staff and we can connect with UVM and make sure we really have that pinned down. The other comment I had is really just clarification. Slide 142, if you could pull that up.
It may take just 1 minute, it has to upload.
So while you're pulling that up, kind of related to the funds flow and the network assets, we also need to bottom out. I know we've been working on it with UVM a little bit. The funds flow document that UVM used to provide, there was affiliation payments and other monies that had gone to New York, and understanding exactly what is where and what's captured in the due tos and due froms, I think also needs a little bit of bottoming out. On this slide here, 142, this is UVM's proposed budget. And their proposed budget has a minus 7.9% rate change for commercial payers. And that's comprised of these variables like the cap from pharmaceuticals from the legislature, and then the board's enforcements and UVM settlement. This is distinct from your recommendation, which is actually another 7.3% reduction on top of this. Am I correct?
On top of the rate increase, yes. About 2.4. Right.
Right. Okay. So the $72 million margin you're saying is not necessary or appropriate this year, given the board statutes and all the issues we have in the healthcare context. And so you're recommending, and that amount equates to the minus, I think you said 7.3. And that would be reduced from their commercial rate proposed increase of 2.3. Okay.
2.4. Yeah.
Okay. Okay, I understand, and I have nothing else. Thank you very much.
Well, I'll hop in if we can ask questions now.
Please.
Matt, can you go to this, that slide with your staff recommendation? And I think I'm asking the same or clarifying the same question that Chair Foster just asked with the percentages, but I'm looking at it with the dollar numbers. So you have the NPR reduction of 72.5 million, and I believe that lines up exactly with the commercial
Yeah.
reduction.
The 72.0 lines up with the commercial reduction.
Oh,
There's an additional for the executive comp on top of that. But yes, yeah.
Okay, so the 72.0 commercial, is that, I'm still struggling with the 23 million, 22 million that was
Yeah.
the commercial rate increase.
Yep.
So does that 72 million include, or is it on top of? Do you know what I mean? Is it net? Is it net?
It includes, yes. So you could think of a portion of the decrease related to that 2.4% increase, but it's like the Venn diagram of the 72.0 million includes that 2.4.
So let me just ask one more way. Would it be 50 million if they hadn't asked for the 2.4% increase?
It would.
We can follow up later. I think I
Yeah,
understand.
mathematically, yes. But for that 2.4% increase, the reduction to get to a 0% operating margin, all else equal, would be that like 58.
50 million.
Ballparking, yeah.
Okay. Yes, that was my question. Thank you. I appreciate the clarification.
Hey, Matt, it's Tom. Thank you for this. While you have the slides up, could you go to slide 148, please? And maybe it was 149 then right after. Oh, sorry, we lost it.
I do want to actually, I caught something while Mark was presenting the recommendations. I had the wrong hospital. This table right here, I was showing Copley's table rather than UVM's previously. I updated this while we were going through the slides. So if anyone caught that mistake, I do apologize. I just now fixed that.
Nope. That's fine, thanks. There was a slide, I'd written 148 as the slide to go back to, talking about Medicare reimbursements being higher, the red line going to the right here. And on one of the slides associated with that, there was a comment, I believe, written on there about a wage index change driving some of that. And I just wanted to make sure that I saw that correctly. It may be the slide before or after. If the slides have been, let's go. We'll look at it together. I just wanted to better understand that. The theme throughout, as Mark was saying, operating expenses have been growing over budget year over year, and sometimes equal to or faster than revenue. At the same time, commercial prices and revenue have been growing very rapidly. Did I understand that correctly, that operating income has been negative even with rapidly growing commercial prices and NPR overages? And that
the budget did up.
Yeah, that negative is because of the rapidly rising operating expenses, if I heard you correctly.
That's correct, yes.
Okay. Later on in the cost to charge ratios, some of the ratios did not look as good as other hospitals. But it seems to me that that would be explained by the rapidly rising operating expenses driving up the cost. So one way to fix a ratio of cost to charge that you find unfavorable would be to decrease the costs. Am I seeing that correctly?
Yeah, I think decreasing costs would increase the ratio. Yeah.
Yeah, okay. So the theme over and over are rapidly rising operating expenses and costs. And we've seen some of those costs that are rising. Some of that, what's labeled as a cost, are payments to the network. Is that also correct?
Yes.
Okay. And those have been going up in recent years quite rapidly. Finally, when talking about Mark was talking about the many steps, a dozen steps in negotiating with Blue Cross Blue Shield. I noticed maybe this is a simple thing that should have been understood long ago, but the network is negotiating for all hospitals in the network. The network does the negotiating from that table for Porter and CVMC.
That's my understanding from what we've received from the network. Yes.
Do we have any estimates on either the number of FTEs or the salary amounts for the negotiating team from the network? If not on hand, we can check to see. I'm just wondering. That's something I'd like to know more about.
I don't have that, no.
Okay. All right. And along with Chair Foster, the uncertainty about reserves. I think the liaison letter, the health advocate letter had figures about unrestricted liquid assets or reserves. And I just want to make sure that I'm understanding that correctly, how any of their numbers compare to ours, compared to what was submitted to us. So
yeah, I'll need to spend more time with the letter and cross-reference it with our figures too, but
I know we just got them, and so I understand, but I just want to make sure that I've got those lined up. So thank you very much.
Can I just ask for one quick clarification on this slide, actually? On the right, that operating income is operating income compared to budgeted operating income, right? So on the left, we see 2024 actuals, total income $161.7 million. On the right, 2024 operating income is 1.9 million less than budgeted. But I just want to make sure I understand this.
I think you're looking at total income, but if you maybe if I highlight, it'll make it a little clearer. So here you can see their 24 budget to actual.
Yep.
There's a $1.9 million delta right there that's reflected over here on the budget actuals table.
And that's okay. That's yep. I see that. So budgeted actuals. So that's not the 1.9 is they didn't lose 1.9 million in 2024. They have 1.9 million less than budgeted in 2024.
Exactly. They budgeted 64.5. They made 62.6, and they operating income was less than budgeted despite total revenue being $124 million above budget. It's another way to frame it.
Right. Okay. Yeah, I don't have any other questions right now. Thank you.
I don't have any specific questions. It's a lot to digest, and I really appreciate the staff's time in all of these slides and all of the analysis that went into presenting this 178 slide deck here, 100 and however many pages it is. But just a couple of quick requests. I would like confirmation from UVM and CVMC that the rate, mid-year rate reduction actually did take effect August 1st. I think I am still looking for those purchase services, the breakdown for all of the Vermont hospitals, detailed where those dollars are going. And actually a third request is I did take a look at, we had requested the employee engagement survey, and I noticed that it was summarized in a PowerPoint presentation. Actually, what I'd really like is the actual report from Gallup rather than a summary in the PowerPoint presentation. I'd just like to see that if that's possible. So those are my requests. If we can get that before we have deliberations, that would be really helpful. But I really appreciate staff time here. Very thorough, excellent presentation. Thank you.
I'll turn it to the healthcare advocate for any comments.
Thank you, Mr. Chair and board members and board staff for a great presentation and great discussion. I did want to recognize here that the HCA recommended reducing UVM's commercial charge by an additional 9.6%. This is somewhat more than what is being contemplated here. If the board members or anyone else would like to understand our reasoning for that recommendation, please take a look at our comment posted on the board's webpage and feel free to reach out to us. Thank you, Mr. Chair.
Thank you very much. And Dr. Leffler, are you here?
I am. Thank you, Chair Foster. Thank you, members of the board. Thank you for the staff for putting together this presentation. I will say it's a lot to digest, and so we're still working through that. I do want to just say that I am concerned about the finding that we're not compliant with our budget orders, because we worked very hard to do that, and I believe we had worked through that with the staff. So we'll have to look into that further. That does concern me. The medical center, and I heard Member Holmes's requests. We will get you additional comments and information next week before your board votes. And so thank you for the opportunity to speak today, and we will get that information to you.
Great, thank you. And thank you, Dr. Leffler, to you and your staff and Mr. Vincent and everyone for really being very cooperative and helping us understand all this. It is appreciated. Okay, I think that's all we have on the hospital presentations for today. I will open up to public comment on any of the material we covered today via the raise the hand function. I'll just note the board also has an open public comment period. Anyone can submit any comments they want, and the board will review them and consider them in conjunction with evaluating the staff's proposals, which I believe will potentially be voting on next week. Seeing no public comment, is there any old or new business for the board? Okay, great. Matt, Emma, Janelle, Angela, Mark, just a huge thank you for what you do. It's such a tremendous amount of labor and work, and it was a really high quality presentation. So I really value your public service and your efforts for us. So thank you so much. You did a great job. And with that, I will move to adjourn.
Second.
All in favor, say aye.
Aye.
Aye. And we're adjourned. Everyone have a nice afternoon.